Retinal vascular disease. Let's start by retinal circulation. The first is arterial system and the central retinal artery. It is an end artery, enters the optic nerve approximately 1 centimeter behind the globe. 1 centimeter behind the globe. It is composed of 3 anatomical layers: the edema, the internal elastic lamina, the media, and the adventitia. The edema is the innermost, composed of single layer of endothelium resting on collagenous zone. Then the internal elastic lamina separates the edema from the media. The media consists mainly of smooth muscles, and the outermost is the adventitia. It is composed of loose connective tissue. So the adventitia, connective tissue, the media, the smooth muscle, and the edema, the single layer of endothelium. Then comes after the central retinal artery comes the retinal arterioles. Retinal arterioles arise from the central retinal artery. Their walls contain smooth muscles, but in contrast to arteries, the internal elastic lamina is discontinuous. Then comes the capillaries. The retinal capillaries supply the inner 2/3 of the retina, with the outer third being supplied by choriocapillaries. The inner capillary network or plexus is located in the ganglion cell layer, with an outer plexus in the inner nuclear layer. So there is inner capillary network and outer plexus. The inner plexus and outer. The inner plexus in the ganglion cell layer and the outer plexus in the inner nuclear layer. There is capillary free zones present around the arterioles, and also at the fovea, known as foveal avascular zone. Retinal capillaries are devoid of smooth muscle and elastic tissue. Retinal capillaries walls consist of endothelial cells, basement membrane, and pericytes. The retinal capillary walls consist of endothelial cells, basement membrane, and pericytes. Endothelial cells, they form a single layer on the basement membrane and are linked by tight junctions that form the inner blood retinal barrier. So here is an important point: the inner retinal blood barrier. It is formed by endothelial cells, the tight junctions. So endothelial cells form the inner blood retinal barrier. The inner is the basement membrane. It lies beneath the endothelial cells with an outer basal lamina enclosing the pericytes. So it lies beneath the endothelial cells. The pericyte lies external to the endothelial cells. They have multiple pseudopodial processes that envelope the capillaries. Pericytes have contractile properties and are thought to participate in autoregulation of the microvascular circulation. Then come the venous system. Retinal venules and veins drain blood from the capillaries. The small venules are larger than capillaries but have a similar structure. The larger venules contain smooth muscles and merge to form veins. The veins contain a small amount of smooth muscle and elastic tissue in their walls and are relatively distensible. Their diameter gradually enlarges as they pass posteriorly toward the central retinal vein. Now the diabetic retinopathy. Diabetes is a major concern for healthcare systems throughout the world. The prevalence of diabetes is relentlessly increasing, particularly in working age adults. Diabetic retinopathy is the commonest cause of new blindness in most industrialized countries, mainly because of a delay in obtaining medical treatment. However, with effective screening and by embracing and implementing the conclusions of the early treatment diabetic retinopathy study and the anti-VEGF clinical trials, the risk of severe visual loss can be reduced to less than 5%. What are the ophthalmic complications of diabetes? The common complications are maculopathy such as diabetic macular edema and macular ischemia. Also the common is retinopathy, which is a sequelae arising from retinal ischemia. For example, neovascularization of the optic disc and retina and vitreous hemorrhage is common. Unstable refraction is common. Uncommon are recurrent styes, synthelasma, accelerated age-related cataract, tractional retinal detachment, neovascularization of the iris and angle, neovascular glaucoma, ocular motor nerve palsies, reduced corneal sensitivity, while the rare complications are papillopathy, pupillary light near dissociation, Wolfram syndrome, which is progressive optic atrophy and multiple neurological and systemic abnormalities, acute onset cataract, rhino-orbital mucormycosis. Prevalence. The reported prevalence of diabetic retinopathy in people with diabetes varies substantially among studies and even among contemporary populations in the same country, but is probably around 40%. People with diabetes are often unaware that they might have retinopathy. The prevalence of diabetic retinopathy in type 2 diabetes is 67% 10 years after the diagnosis has been made, and 10% will have proliferative disease. Diabetic retinopathy is more common in type 1 diabetes than in type 2 diabetes. The risk factors. Number 1 is duration of diabetes. It is the most important predictor of diabetic retinopathy. Diabetic retinopathy rarely develops within 5 years of the onset of diabetes or before puberty. People with type 1 diabetes are at particular long-term risk. Duration is stronger predictor for proliferative disease than for maculopathy. Poor control of diabetes. The diabetes control and complication trial shows that tight blood glucose control, particularly when instituted early, can prevent or delay the development or progression of diabetic retinopathy, subsequently confirmed by the United Kingdom prospective diabetes study. However, a sudden improvement in control may be associated with progression of retinopathy. The higher the glycated hemoglobin HbA1c, the greater the risk of complications of diabetes, such as proliferative diabetic retinopathy. In people with advanced retinopathy, even the most rigorous control of blood glucose may not prevent progression. Hypertension is very common in those with type 2 diabetes and should be rigorously controlled to less than 140 by 80 mm of mercury. Tight control of blood pressure appears to be particularly beneficial in type 2 diabetes with maculopathy. Nephropathy. Nephropathy, if severe, is associated with worsening of diabetic retinopathy. Conversely, treatment of renal disease, for example, renal transplantation, may be associated with improvement of retinopathy and a better response to photocoagulation. Drugs. Pioglitazone is associated with a significant risk of worsening of diabetic macular edema. Pregnancy is sometimes associated with rapid progression of diabetic retinopathy. Predicating factors include greater pre-pregnancy severity of retinopathy, poor pre-pregnancy control of diabetes, control exerted too rapidly during the early stages of pregnancy, and last is pre-eclampsia during pregnancy. The risk of progression is related to the severity of diabetic retinopathy in the first trimester. Approximately 5% with mild diabetic retinopathy and a third of those with moderate diabetic retinopathy will progress to progressive diabetic retinopathy during pregnancy. If substantial diabetic retinopathy is present, frequency of review should reflect individual risk and can be up to 2 weekly. Diabetic macular edema usually resolves spontaneously after pregnancy and might not need to be treated if it develops in late pregnancy. Other risk factors include hyperlipidemia, cataract surgery, and anemia. Pathogenesis. Diabetic retinopathy is predominantly a microangiopathy in which small blood vessels are particularly vulnerable to damage from high glucose levels. Direct hyperglycemic effect on retinal cells are also likely to play a role. Many angiogenic stimulators and inhibitors have been identified. Vascular endothelial growth factor appears to be particularly important in the former category. Classification is used in the early treatment diabetic retinopathy study ETDRS. The modified Early-House classification is widely used internationally. In conjunction with management guidelines, which we will discuss, these descriptive categories are also in widespread use in clinical practice. Number 1 is background diabetic retinopathy. It is characterized by microaneurysms, dot plot hemorrhages, exudates. These signs generally are the earliest signs of diabetic retinopathy and persist as more advanced lesions appear. Diabetic maculopathy refers to the presence of any retinopathy at the macula, but is commonly reserved for significant changes, particularly vision-threatening edema and ischemia. Pre-proliferative diabetic retinopathy (PPDR) manifests with cottonwood spots, venous bleeding, intraretinal microvascular anomalies, moderate to severe retinal hemorrhages. It indicates the progressive retinal ischemia with a heightened risk of progression to retinal neovascularization. In proliferative diabetic retinopathy, there is neovascularization on or within one disc diameter of the disc and are new vessels elsewhere in the fundus. High risk PDR, there is either the presence of vitreous hemorrhage or pre-retinal hemorrhage or presence of any active neovascularization or location of the neovascularization on or within one disc diameter of the optic disc or neovascularization at the disc more than 1/3 disc area or neovascularization elsewhere more than half disc area. Elsewhere more than half, at the disc more than 1/3. Advanced diabetic eye disease is characterized by tractional retinal detachment, significant persistent vitreous hemorrhage, and neovascular glaucoma. This is another classification, early treatment diabetic retinopathy study classification, ETDRS classification of diabetic retinopathy. We will discuss this classification after we discuss the signs. So we will discuss this classification after we discuss these signs. The first sign is So there are many signs in diabetic retinopathy, depending upon the severity of diabetic retinopathy. The first one is microaneurysms. They are localized outpouching, mainly secular of the capillary wall. So secular outpouching of the capillary wall. That may form either by focal dilatation of the capillary wall, where pericytes are absent, or by fusion of the two arms of a capillary loop. Most develop in the inner capillary plexus at the ganglion cell layer, frequently adjacent to areas of capillary non-perfusion. Loss of pericytes may also lead to endothelial cell proliferation with the formation of cellular microaneurysm. These are cellular microaneurysms. Microaneurysms may leak plasma constituents into the retina as a result of breakdown in the blood-retinal barrier, or may thrombose. Microaneurysm may thrombose. They tend to be the earliest signs of diabetic retinopathy. They are in the earliest signs of diabetic retinopathy. Clinically, they may be seen as tiny red dots. Here you can see tiny red dots, maybe often initially temporal to the fovea, may be indistinguishable clinically from the dot hemorrhages. So these are actually the microaneurysm, and also there are dot blot hemorrhages at the posterior pole. On fluorescein angiography, it allows differentiation between dot hemorrhages and non-thrombosed microaneurysms. Early frames show tiny hyperfluorescent dots, typically more numerous than visible clinically. Late frames show diffuse hyperfluorescence due to leakage. OCT shows microaneurysms in the middle retinal layers. Normal vessels look similar to microaneurysms, but are usually seen in the inner retinal layers. Retinal hemorrhages. The next sign is retinal hemorrhages. Retinal nerve fiber layer hemorrhages. It is divided into nerve fiber layer hemorrhages, intraretinal hemorrhages, deep dark round hemorrhages. The first is retinal nerve fiber layer hemorrhages, arise from the larger superficial precapillary arterioles and assume their characteristic shape because of the architecture of the retinal nerve fiber layer. So these are retinal nerve fiber layer hemorrhages. This image of histology shows blood lying diffusely in the retinal nerve fiber and ganglion cell layers and as globules in the outer layers. So these are outer layers in which it is like globules. Here you can see retinal nerve fiber layer hemorrhages. These look like flame-shaped hemorrhages. Next is intraretinal hemorrhages. They arise from the venous end of capillaries. They are located in the compact middle layers of the retina. Here you can see the middle layers of the retina with a resultant red dot blot configuration. They look like dot blot, so they These are dot plot hemorrhages, as you can see in these pictures. These are intraretinal hemorrhages. So these are dot and blot hemorrhages. As you can see, these are multiple dot blot hemorrhages. After intraretinal hemorrhages, then comes the deeper dark round hemorrhages. So as you can see here, deeper dark round hemorrhages represent hemorrhagic retinal infarcts and are located within the middle retinal layers. The extent of involvement is a significant marker of the likelihood of progression to progressive proliferative diabetic retinopathy. So these are deep dark hemorrhages, as you can see. Next come the exudates. The exudates, as you can see in these pictures, these are caused by chronic localized retinal edema. They develop at the junction of normal and edematous retina. They are composed of lipoprotein and lipid-filled macrophages located mainly within the outer plexiform layer. The outer plexiform layer, here you can see they are located in the outer plexiform layer. They appear as waxy yellow lesions with relatively distinct margins arranged in a clumps and or rings at the posterior pole, often surrounding leaking microaneurysms. With time, the number and size tend to increase. Here you can see the fovea may be involved. When leakage ceases, exudates absorb spontaneously over a period of months, either into healthy surrounding capillaries or by phagocytosis. Chronic leakage leads to enlargement and deposition of crystalline cholesterol. Here you can see. So exudates involving the fovea, including the central crystalline cholesterol deposition. These are the cholesterol deposition, and here it is more extensive exudates forming a circinate pattern. This is circinate pattern, and these are small exudates and microaneurysms. Diabetic macular edema. Diabetic maculopathy, which consists of macular edema, macular exudates, macular ischemia. So the maculopathy consists of macular edema, either macular edema or macular exudates or macular ischemia. Diabetic macular edema is the most common cause of moderate visual impairment in diabetic patients, particularly type 2. Diffuse retinal edema is caused by extensive capillary leakage. And localized edema occur by focal leakage. So there is focal leakage and there is extensive capillary leakage. The focal leakage occurs from microaneurysms and dilated capillary segments. The fluid is initially located between the outer plexiform and inner nuclear layers. Later, it may also involve the inner plexiform and nerve fiber layer, until eventually the entire thickness of the retina becomes edematous. The diabetic macular edema is readily detectable using OCT. Here you can see cystide macular edema, OCT showing retinal thickening and cystide spaces, and this is the FA showing leakage, microaneurysms, central diffuse hyperfluorescence with a flower petal configuration. Clinically significant macular edema is defined in the ETDRS as retinal thickening within 500 micrometer or 1/3 disc diameter. Retinal thickening of 1/3 disc diameter of the center of the macula. So retinal thickening within 500 micrometer or 1/3 disc diameter of the center of the macula. Or clinically significant macular edema may also be the hard exudates within 500 micrometer of the center of the macula. So the first one was within 500 micrometer of the center of the macula, retinal thickening, and here it is the hard exudates within 500 micrometer of the center of the macula, with adjacent retinal thickening which may lie more than 500 micrometer from the foveal center. So here only thickening, and here hard exudates, and inner is retinal thickening, one disc area or larger, any part of which is within 1 disc diameter of the center of the macula. Center of the macula. So one is focal maculopathy and another is diffuse maculopathy. Focal maculopathy is a well circumscribed retinal thickening associated with complete or incomplete rings of exudates. Here you can see rings of exudates. The FA shows late focal hyperfluorescence due to leakage, usually with good macular perfusion. Diffuse maculopathy, the diffuse retinal thickening, which may be associated with cystite changes. There are typically also scattered microaneurysms and small hemorrhages. Landmarks may be obscured by edema, which may render localization of the fovea impossible. FA shows mid and late phase diffuse hyperfluorescence. So here it is diffuse retinal thickening, and here it is well circumscribed retinal thickening. Now come to ischemic maculopathy. The sign will be the signs of ischemic maculopathy. The retina often shows dot blot, hemorrhages, and cartonule spots, but the macula may look relatively normal despite reduced visual acuity. The FA shows capillary non-perfusion at the fovea. There will be an enlarged foveal avascular zone, and frequently other areas of capillary non-perfusion at the posterior pole and periphery. Now the cartonule spots, they are composed of accumulations of neuronal debris within the nerve fiber layer. They result from ischemic disruption of nerve axons, the swollen ends of which are known as cystite bodies, seen in light microscopy as globular structures in the nerve fiber layer. As cartonule spots heal, debris is removed by autolysis and phagocytosis. Signs are there are small fluffy whitish superficial lesions that obscure underlying blood vessels. They obscure underlying blood vessels. They are clinically evident only in the post-equatorial retina, where the nerve fiber layer is of sufficient thickness to render them visible. The FA shows focal hypofluorescence due to local ischemia and blockage of background choroidal fluorescence. OCT shows cottonwool spots in the retinal nerve fiber layer, which shows a hyperreflective pattern in the acute stage. About 80% of the cottonwool spots have hyporeflective cavities appearing as cysts. Venous changes. Venous anomalies seen in retinal ischemia consist of generalized dilatation and tortuosity. There is looping, beading, which is focal narrowing and dilatations, and sausage-like segmentation. The extent of the retinal area exhibiting venous changes correlates well with the likelihood of developing proliferative disease. So these are the venous changes. Venous changes is looping, there is beading, there is segmentation. Intraretinal microvascular abnormalities, ETDRS, are arteriolar venular shunts that run from retinal arterioles to the venules, thus bypassing the capillary bed, therefore often seen adjacent to areas of marked capillary hypoperfusion. The signs are there are fine, irregular, red intraretinal lines that run from the arterioles to the venules without crossing major blood vessels. FA shows focal hypofluorescence associated with adjacent areas of capillary closure or dropout but without leakage. So they can be differentiated from neovascularization. In neovascularization there is leakage. Profound leakage of fluorescein occurs in neovascularization, but here there is no leakage. OCT, unlike new vessels, ETDRS do not breach the internal limiting membrane. Arterial changes. Subtle retinal arteriolar dilatation may be an early marker of ischemic dysfunction. When significant ischemia is present, sign induce peripheral narrowing, silver wiring, obliteration, similar to late appearance of following branch retinal artery occlusion. Proliferative retinopathy. Although pre-retinal new vessels may arise anywhere in the retina, they are most commonly seen at the posterior fold. Fibrous tissue, initially fine, gradually develops as vessels increase in size. New vessels at the disc. NVD describes neovascularization on or within one disc diameter of the optic nerve head. So these are new vessels at the disc. These are new vessels at the disc. These are moderate new vessels. These are severe with cottonwool spots. And this is the FA showing leakage disc vessels with extensive peripheral capillary dropout and a small focus of leaking vessels every elsewhere. Now new vessels elsewhere describe neovascularization further away from the disc. So these are the new vessels elsewhere. These are mild new vessels elsewhere. These are severe new vessels elsewhere, and these are associated with fibrosis. New vessels on the iris, also known as rubeosis iridis, carry a high likelihood of progression to neovascular glaucoma. The FA highlights neovascularization during the early phases of the angiogram and shows irregular expanding hyperfluorescence during the later stages due to intense leakage of the dye from the neovascular tissue. FA can be used to confirm the presence of new vessels if the clinical diagnosis is in doubt, and also delineates areas of ischemic retina that might be selectively targeted for laser treatment. OCT of the retina is good at detecting new vessels, 100%, but not regression, so 45%, or reactivation, only 10%. However, OCT angiography is useful for the objective monitoring of disease after a treatment. Now we will come to the classification. Early treatment diabetic retinopathy study classification broadly divides into non-proliferative and proliferative diabetic retinopathy. The non-proliferative is further divided into no diabetic retinopathy, very mild, mild, moderate, severe, and very severe. No diabetic retinopathy review in 12 months. Very mild NPDR, in which there are microaneurysms, review most patients in 12 months. So very mild and then mild. In mild, there are any or all of microaneurysms, retinal hemorrhages, exudates, cotton wool spots, up to the level of moderate NPDR. No intraretinal microvascular abnormality or significant bleeding. Review range from 6 to 12 months depending on the severity of signs, stability, systemic factors, patient personal circumstances. A mild NPDR, we should distinguish it from the moderate NPDR. Mild from moderate. The moderate NPDR, also there are several severe retinal hemorrhages. In mild and moderate, in both there are retinal hemorrhages, but in moderate there are severe retinal hemorrhages, more than ETDRS standard photograph 2A, which means about 20 medium large per quadrant in 1 to 3 quadrants, are mild edema. So if the hemorrhages are less than 20 and less than 1 quadrant, so then this is mild. If it is in 1 to 3 quadrants and about 20, then this is moderate. And there is significant venous bleeding in no more than 1 quadrant. So bleeding only in 1 quadrant. In moderate NPDR, bleeding in only 1 quadrant. Cotton wool spots commonly present. Review in 6 months. Because proliferative diabetic retinopathy occurs in up to 26% of these patients, and high risk PDR in up to 8% within a year. So that's why 6 months are necessary. Now, how to differentiate moderate from severe? For severe, there is 4 to 1 rule. It is very easy because 4 means severe hemorrhages in all 4 quadrants. So if you see severe hemorrhages on 4 quadrants, this is severe NPDR. Or if you see significant venous bleeding in 2 quadrants, it is also severe NPDR. And if you see only moderate edema in 1 or more quadrant, it is also severe NPDR. So here edema comes, a new sign is edema. Review in 4 months. Why? Because PDR in up to 50%. In the previous, PDR was only in 26%. And here PDR in about 50%. High risk PDR 15% within a year. 8% within a year. 15. So from 26, the risk increases to 50% in a year. Now from above severe we go to very severe. Very severe, there is 2 or more of the criteria if two or more of these three signs are present, two or more of these signs, if you see hemorrhages in addition to hemorrhages, venous bleeding, then it is very severe. Review in 2 to 3 months, because high risk PDR in about 45%, high risk in 15%, and high risk PDR in 45%. Then comes proliferative. Proliferative, the main thing is new vessels on the disc or elsewhere, but extent insufficient to meet the high risk criteria. So it should be distinguished from the mild moderate PDR should be distinguished from high risk PDR. How? In high risk there is the NVD is greater than ETDRS standard photograph, which means about 1/3 disc area. So greater than 1/3, it is high risk PDR. Greater than 1/3 is important. Any NVD with vitreous hemorrhage, then it is high risk PDR. Or any NVE greater than half disc area. So these are important. NVD more than 1/3 disc, and NVE more than half disc. NVD more than 1/3 of a disc, NVE more than half disc area with vitreous hemorrhage. Here no vitreous hemorrhage, but with NVE it should be vitreous hemorrhage to declare it high risk. So here treatment considered according to severity of signs and stability, systemic factors, circumstances such as reliability of attendance for review. If not treated, review in up to 2 months. And here treatment advised, which we will discuss, it should be performed immediately when possible, and certainly same day asymptomatic presentation with good retinal view. So if you see NVD greater than 1/3, so direct treatment. And advanced diabetic eye disease, which we have already discussed.